Good day everyone, I am Akshaya Muthu and today I'll be presenting on my final year project synthesizing missing modalities for brain MRI tumor segmentation. Let's get started. In this presentation, I will first cover the introduction of the project followed by proposed model, experiments and results, and conclusion. Let's begin with the introduction. As for some background information, gliomas are abnormal and uncontrolled growth of cells originating in the brain, and in 2021, it is expected that almost 85,000 people will be diagnosed with brain gliomas in the United States. Magnetic resonance imaging, known as MRIs, are widely used by radiologists and doctors for the detection and segmentation of diagnosed brain tumors. This is because they provide intricate and anatomical details and information about the brain tumors. Therefore, there is a demand for medical practitioners to analyze MRIs. Multimodal images are commonly used in medical imaging tasks such as image synthesis and segmentation. These multiple modalities provide brain information variability and information diversity, which aids in improving diagnosis and segmentation performance. This slide shows the 4 common modalities. In the images, you can see how the tumors show up differently in each modality and the different tumor types are more distinct in each modality. For example, in T1 and T2, we can view that the tumors appear darker, while in T1CE and FLAIR they appear bright. Hence, from research, we can deduct that the T1 and FLAIR modalities are more suitable to detect tumors with the peritoneal edema, while T1 and T1CE modalities are best fitted to detect the tumor core. Hence, this shows the importance of having the various MRI modalities. However, it is frequent in clinical practices that the patient might have some missing modalities. This can be due to accidental patient movements that cause noise, artifacts, and low quality and systemic errors in the images. Patients with kidney failures and allergic reactions also miss the contrast-enhanced T1CE modality since they cannot use the contrast enhancement agent gadolinium due to their pre-existing conditions. Limited MRI scanning time also causes patients to lose the FLAIR modality as that modality requires the longest scanning time. As for related works for image translation, there are 2 types of image translation methods currently being used, unimodal and multimodal image translation methods. Cycle GAN and 3D autoencoder GAN is a unimodal methods that translate one source modality to a target modality and vice versa. However, these methods neglects multimodal data. Multimodal methods such as star GAN and color GAN are able to carry out end-to-one image translation. However, they neglect the 3D data and only use 2D slices data for image translation. As for tumor segmentation, there are CNN, RescueNet, and Pix-to-Pix GAN models. All these models require all MRI modalities discussed previously to be present to carry out tumor segmentation. Pix-to-Pix GAN was a model developed by Philip Isola and an implementation of the conditional GAN, which has a generator and discriminator network. Therefore, we have discussed the following research gaps from the related works. Firstly, existing models are unable to handle missing modalities and input data and are unable to carry out multimodal image translation and use 3D image data simultaneously. My project aims to tackle the research gaps identified in the current methods. My project's aims would be to develop a general adversarial network to generate missing modality and tumor segmentation output, which would be a novel 3D cascaded Pix-to-Pix combined model to tackle and alleviate these 3 research gaps identified. Following the development of the proposed model, the model will be evaluated using the corresponding performance metrics and compared and evaluated with other models. Proposed model. The data we use for this project is the brain tumor segmentation known as BRAD's 2019 dataset. There are 369 multimodal MRI 3D image data which were already pre-processed by being skull stripped and registered. Each data also contained the segmentation output manually segmented and approved by experienced neuroradiologists. As for data pre-processing, we first carried out histogram equalization and image normalization. Following that, we carried out data augmentation by using 3D flipping and 3D rotation methods. Finally, we carried out patch augmentations where the data is zoomed and cropped to 3D patches of sizes 128 x 128 x 128. This is the proposed model, a 3D cascaded peaks-to-peaks model. The model is made up of two stages with two networks. The first stage involves missing modality synthesis, and the second stage carries out tumor segmentation. For our experiments, we assume that patients only have three existing modalities, and each network has an autoencoder GAN to generate the outputs and a patch GAN discriminator. Looking at the diagram, we can see that the input to the first stage would be three existing modalities. The missing modality will be synthesized using the autoencoder GAN made up of the model encoder and model decoder. The real modality ground truth and the synthesized modality are fed to the patch GAN discriminator. Following the synthesis of the missing modality, concatenation of the existing modalities and synthesized modality is carried out, and the concatenated input is fed as the input to the second stage of the model. This input is used to train the model to output the tumor segmentation. This slide shows the specific layers and structure of the autoencoder generator and patch GAN discriminator of the missing modality synthesis network. In the autoencoder generator, the input modalities are downsampled over a few layers until the input is compressed into a reduced dimension and is upsampled again. The patch GAN discriminator takes the synthesized missing modality and ground truth missing modality and predicts whether the synthesized image is real or a generated fake. The second stage of the network is for tumor segmentation. The input of the autoencoder generator would be the concatenated existing modalities with the output of the first stage of the network. The general architecture of the model is the same as that of the network in stage 1 of the model. This is the detailed architecture diagram of the proposed model showing the two stages of the network. We use two sets of performance metrics to evaluate the output of the model. The synthesized modality of stage 1 of the model is evaluated using the structural similarity index metric and peak signal noise ratio. The tumor segmentation outputs are evaluated using die-scores. Experiments and results. For tumor segmentation, we carried out experiments with the proposed model with each modality as the missing modality. We carried out similar experiments with the same missing modality with comparison models, peaks-to-peaks, and convolutional neural networks. We also carried out a benchmark peaks-to-peaks experiment with the complete data, which is the full 4 modalities, for evaluation of our proposed model. Looking at the simplified results table, we can see that our proposed model outperforms significantly better than the comparison models for all missing modality experiments. We can see that the proposed model is able to achieve high die-scores, which were almost comparable to the benchmark die-score of 0.8621 obtained using complete modality data. We can also see the significant improvement of die-scores using the proposed model compared to the CNN and peaks-to-peaks comparison models, which were unable to handle the missing modality and achieved poorer die-scores. This slide shows the examples of the tumor segmentation outputs produced for each missing modality experiment. We can notice that the tumor segmentation results produced using the proposed cascaded 3D network outperforms the comparison peaks-to-peaks experiments, and is much more closer and similar to the ground truth, showing the better performance and success of the proposed model. Moving on to the conclusion. In conclusion, the proposed model achieves the project aims by fulfilling the 3 research gaps previously identified by firstly handling missing modalities, using 3D patches as input, and carrying out multimodal image translation using all modality information. In conclusion, we can convincingly determine that the 3D cascaded peaks-to-peaks model is able to achieve better tumor segmentation performance with the help of the intrinsic modality data augmentation method, as seen by the higher die-scores achieved by the proposed model relative to comparison models. However, I do recognize there are some limitations and room for improvement with the proposed model. The model requires separate training of 2 stages and 2 iterations of training, which requires twice the training time of a typical network for training of the 2 separate networks. Also, the 2 networks are mutually exclusive and there is no information sharing between the 2 stages of the networks, which could improve the performance of the network and tumor segmentation results. These improvements identified, we aim to improve the network from a 2-stage cascaded network to a single end-to-end network to simultaneously produce the missing modality and tumor segmentation output. The improved network will also enable information sharing. The extended proposed model is being submitted for patenting and a technical disclosure is currently being written for the model. Therefore, the details about the model architecture has to be withheld in this presentation. With that, I end my presentation. Thank you for your kind attention.